And I'm very pleased to invite Dr. Haider, who is an associate professor in the Division of Infectious Disease at McMaster University Health Science Center. Dr. Haider is the director of the HIV/HCV co-infection clinic and also the director of the internal medicine residency program at McMaster University. His research focuses on tropical medicine and HIV infection, but also on immunocompromised patients, including HIV, cancer, and transplant patients. So thank you, and now Dr. Haider.
Thank you. Well, thank you very much, Jean-Pierre, and thank you for the opportunity to actually share some clinical cases, which hopefully will put the first two talks and bring it to the clinical floor. I think at the end of these cases, you will probably think that Curtis shouldn't, I'll probably agree with Curtis, I think we're going to need God to help us as we move forward. So here we go. So with that in mind, this is a 42-year-old gentleman who was from El Salvador, who came to Canada actually in 1989 and was doing very well till unfortunately around August 2011 when he presented to his local family doctor complaining of some poor exercise tolerance, a bit of pain in his tailbone, and a lot of MSK symptoms. Unfortunately, the news was not good. He was in fact pancytopenic on routine workup. And to move the story forward, he had a leukoerythroblastic picture, a bone marrow was done, and unfortunately the diagnosis was that of non-Hodgkin's lymphoma of the Burkitt subtype. He also had a CSF analysis done. This was done when he came to the hospital and was seen by the hematologist, and unfortunately there was in fact CNS involvement with his lymphoma. An astute hematologist and oncologist, because we do work together at our university, did do an HIV test at baseline, and the HIV test was in fact positive. He had an HIV viral load of just under 100,000, the CD4 count of 70. His genotype at baseline was wild type, and he was seen by the inpatient infectious disease service, and a decision at that time by the team that was on was to actually start him on Truvada and boosted darunavir, and there could certainly be discussions about whether or not that would have been the most appropriate choice at the time, but that's what was started, and I think it's actually fairly reasonable. He was put on dapsone. The reason for dapsone was not because he had a septal allergy. The issue was that they were looking ahead a little bit, and they were worried about the marrow suppressive effects of concomitant chemotherapy. Some other relevant baseline serologies were all negative. A little bit about him. He's heterosexual, married for the last 9 years. He had one extramarital relationship, and he was fairly adamant that that was his potential exposure to HIV. Denied any history of IV drug use, though notably did have a number of tattoos. So what happened with him next? This is to kind of highlight the complexities of treating HIV and concurrent malignancies. He was started on Codox M-IVAC, and I have to give my hematologists and oncologists full credit on these acronyms because only they know what they mean, but I'm soon going to make it simpler, as well as some intrathecal chemotherapy given to treat the CNS involvement with his lymphoma. Now, the good news was that, in fact, he did do well with this induction course of chemotherapy, and he actually cleared his CSF lymphoma cells, but unfortunately, later on had a recurrence both in peripheral blood and bone marrow, so the story will carry on in a few minutes. What about his HIV status? Well, his HIV viral load actually did respond quite well to the darunavir-based regimen. Within 2 months, I should say, he was virologically suppressed. Now, his CD4 counts are quite low, and they haven't moved, but again, remember, he's receiving concomitant chemotherapy. The percent CD4 counts are actually fairly reasonable. But the story gets a bit more complicated. During his treatment for his lymphoma as well as his HIV therapy, he then develops intolerance, gets a lot of GI symptoms, nausea, vomiting, and flatulence. And then the HIV service was asked to come and reassess him to say, was the antiretroviral regimen contributing to this intolerance? So just to kind of highlight to you the complexities of these acronyms, I don't expect you to memorize, there won't be a test for this at the end, but just to show you that in fact these are multiple drugs with different target sites. So an example is what you're seeing in front of you is what this patient received. But what I'm going to highlight is the issue of drug-to-drug interactions. So your next question, so you've decided that in fact the ARV regimen may be contributing to some of the GI symptoms, and you're asked to make a switch. You have a number of options. You may decide actually not to switch and leave him on Truvada and boosted darunavir. Another option might be a triplet. Third option, Kyvexa nevirapine, and the last option, Kyvexa reltegravir. Curtis, what would you have gone with?
So, there's a number of issues here to consider. Clearly, there's a pill burden issue, but I think even if you get a person down to a 1 pill once a day regimen for their HIV treatment, they're still going to be on 1 billion pills trying to manage this lymphoma. So that might help the situation, but I don't think that's the most critical thing that I'd be thinking about in whether I'd make a change or not. I'd have to consult my HIV clinic pharmacist to remind me about the drug-drug interactions between the chemotherapy drugs and the protease inhibitors and NRTIs. And if you know, I'm assuming there are big interactions between both of those classes of drugs. Because they're both metabolized through the liver. And with that in mind, I guess raltegravir would be a reasonable choice. As far as the nucleosides go, I'm less concerned about that, although there are some drug interactions with tenofovir that you need to consider.
Yeah, I think those are all very, very reasonable comments. And I think actually our decision was we actually went with raltegravir mainly because of the drug-to-drug interaction issues, which will be highlighted now in this next slide. So I think just to kind of outline the fact that if you look at classes of ARVs, and we can look at NNRTIs, the major issue with drugs like nevirapine, efavirenz, etravirine is that they're obviously potent CYP inducers, CYP3A4 inducers. And a lot of the chemotherapeutic agents you're seeing on the left side, take cyclophosphamide as an example, doxorubicin, they're all metabolized by 3A4. So if you have an induction effect, one of the consequences of that is that you can actually lower the active metabolite concentration of the chemotherapeutic drug. So the effect of that is that you can actually decrease the efficacy of your chemotherapeutic agent. The counter side as an HIV physician is the issue of toxicity. So on the counter side, if you have protease inhibitors, which are potent 3A4 inhibitors, the opposite effect can happen. You can raise the levels of some of these chemotherapeutic agents, and it has clinical significance. If you raise the level of cyclophosphamide, you get hemorrhagic cystitis. If you raise the levels of paclitaxel or vincristine, lots of disabling peripheral neuropathy. So you're absolutely right, Curtis. This is where we need some help. Pharmacists, God, whoever we can call to give us some help in managing these patients. But I think it highlights the complexity of what's happening. Well, the good news is this patient actually has done well. He went on a salvage chemotherapy regimen, received 3 cycles of it. The DAP really just stands for, in case you were interested, was dexamethasone, a drug called cytarabine and prednisone. And he actually did achieve remission, but because of the fact that he had relapsed after his initial course of treatment, the algorithm was to actually prepare him for an autologous transplant. And I'm sure a few of you do have patients in your practice who have moved to autologous transplants. Actually, this is my 3rd patient in my own practice that's done this. He went for an autologous transplant, actually did quite well, and post-autologous transplant so far, he has remained in remission. And again, from the perspective of his HIV, we made the decision to go with Kivexka raltegravir because it really is the mechanism of metabolism that was highlighted a little earlier. The glucuronidation issue is really not an issue for chemotherapeutic agents. So I think really a safe and reasonable choice and well tolerated. And he, as you can see, remains virologically suppressed. So that really was meant to kind of highlight the importance of tolerability, drug-to-drug interactions, and complexities that go forward.
Just another comment. Like I said before, no matter what you do, this guy is still going to be on a gazillion pills. And this patient needs Bruno's help.
Right.
To try and figure out a way to deal with all of this. So, you know, writing the prescription has become easy for HIV. It's all the psychosocial stuff that are the big barriers.
Now, next case, you had Curtis show you some data around co-infection. The reality is that we've learned a lot of our co-infection from mono-infection data and clinical experience. This is actually a mono-infected case in my practice, meant to kind of highlight this whole importance of the complexities of treatment here in the world of telaprevir and boceprevir. So this is a 55-year-old gentleman. He has chronic hepatitis C. He has sort of the typical metabolic syndrome, NIDM, on metformin, so his diabetes, he's on metformin. He's got a high cholesterol level, he's on Crestor, and he has this thing called non-alcoholic fatty liver disease, which appears to be a bit of an epidemic now in North America. Everybody seems to have this. His risk factors is that he was a remote drug user in the 1970s with methamphetamines. He's married, however, for the past 30 years in a monogamous relationship. And so you're seeing that he certainly meets the criteria for chronic hepatitis. His liver enzymes are certainly elevated for a period of 6 months. And his HCV viral load was 3.94 times 10 to the 7th international units per ml. He's a Geno 1. Now you notice the next thing is something called APRI. And APRI is something I actually like to do a lot in my clinic. It's a biochemical test. It's an indirect marker of fibrosis. It has its limitations, but the good news is you can do it bedside. Just a quick question for Curtis, because he's our Hep C expert here. Do you use APRI? Where do you use it? Do you think it still has a role?
Yeah, no, I think it's a useful in outpatient measure. You know, it's inexpensive. Anybody can do the calculation. You don't need to buy a $100,000 FibroScan machine. So yeah, it's useful, but you have to recognize the limitations, and it's where you get to point 4. There's other things that reduce your platelet counts, so you need to account for those. And there's things that can affect your liver enzymes that you know, go beyond just hepatitis C. So,
and in fact, I think to give credit to Marina and Curtis, the work done in HIV, merely Marina, certainly the work done for the APRI score in HIV, in fact, was done by the group here. So certainly it has been validated in co-infected patients. All right, I come from a center that about 4.5 weeks ago finally got a FibroScan machine. So we were the biopsy center, I think, around Canada. So we do a lot of biopsies, and this patient had a biopsy, and I'll just take you to the meat of the matter. He had certainly evidence of moderate inflammatory scores and moderate fibrosis, grade 2, stage 2 disease on the biopsy. And so a decision was made to, in fact, treat him. And we, in fact, ended up treating him with triple therapy, boceprevir, pegylated interferon alpha 2A, in fact, and ribavirin, 600 in the morning, 400 milligrams in the evening. Now, he did actually quite well initially at week 8, which, if you remember, for boceprevir, there is a 4-week lead-in phase where you simply give pegylated interferon and ribavirin without the direct-acting agent. And then at 4 weeks, you introduce boceprevir. So this is the 8-week results. So in fact, the viral load had gone down from 10 to the 7th, and it was, in fact, detected but not quantifiable. And that's this whole issue of the LLQ, which stands for lower limit of quantification versus lower limit of detection. So just to remind you, in the boceprevir trials that were done, the TACMAN2 assay had a lower limit of quantification of 25, but a lower limit of detection of about 9.3. And it's now clear that there's some clinical significance to actually getting that lower limit of detectability rather than the lower limit of quantifications. So what happened to this patient? Remember, he is detectable at week 8, but we can't quantify it. Subsequent measurements are all good. He's undetectable at 12, 24, and 48 weeks of therapy. Based on some rather complex rules that I have to look up every time, he actually did get the full course of treatment. He didn't qualify for response-guided therapy because he was not undetectable between weeks 8 and 24. He did go on actually to achieve undetectability at his SVR12 visit, and there was one issue that came up, which was anemia, and I think that Curtis had highlighted that, and we did, in fact, dose adjust him, and despite that dose adjustment, he, in fact, did quite well. So I won't bore you with this, but just to kind of highlight the fact that there are these algorithms that you need to have at your bedside, because no one's going to remember this. They're different for telaprevir, they're different for boceprevir. They certainly vary depending on whether you're talking about a treatment-naive patient or a treatment-experienced patient. So I'll bring it to an end in the interest of time, and I think there's a case left for Curtis to do. No? Okay. So we'll bring that to an end. Thank you.
Thank you very much. For the sake of time, we will end up the meeting now. If you want to be invited next year in Vancouver, you better fill out the evaluation form for the Merck Symposium. So it's bilingual. You can choose your favorite language. Please fill out the forms. That's very important to assess the quality of the objective to be learned. So thank you very much. Thank you to Merck to organize such a highly academic symposium. Thank you, and oral session start now. Thank you very much. Poster, yeah, poster.